This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name, unless referring to a medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand. Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest RANZCOG guidelines, ANZJOG research and other key clinical resources through in-depth conversations with leading experts in obstetrics and gynaecology. I'm Dr Anna Clare, a general gynaecologist based in Perth, with a special interest in vulval health. I'm also a member of the Australian-New Zealand Vulvovaginal Society and recently contributed to the O&G magazine issue focused on the vulva, a theme that ties in with today's topic. Today we're talking about vulval disorders, particularly lichen sclerosus, a common yet frequently under-recognised vulval condition that if left untreated can lead to poor outcomes for patients. Joining me is an expert clinician, Dr Tania Day, who specialises in managing vulvovaginal conditions. Welcome, Tania.
It's a delight to be here, thank you. I'm Dr Tania Day, and I'm a gynaecologist in Newcastle, New South Wales. I've spent more than a decade of clinical practice focused on vulvovaginal disease, and my research is centered on the clinicopathologic diagnosis of skin disorders and on HPV-associated disease of the lower genital tract. I was a co-editor and contributing author to the ISSBD Practical Guide to Diagnosis and Management of Lichen Sclerosus. We'll be drawing a lot on that book today.
And what was it that originally drew you to vulval conditions? I mean, obviously it's quite a niche area within the field of obs and gynae. And what is it that you love about the field now?
There's so many things that I actually love about my work. One of them is that there is just an unmet need that is enormous in the community for this type of care. And the women that we take care of are extremely grateful for receiving a diagnosis and having effective management. And you have continuity of care with them over many years. Mm-hmm. You also get to interact with a really interesting set of professionals because the field overlaps with dermatology and pathology and sexual health and physiotherapy. And you do a lot of colposcopy. And so it's intellectually stimulating. And then you get to draw on all these different approaches to care that you learn from your colleagues. And then finally, vulval cancer is a preventable disease. And for me, it's a really cool and important career goal to do my part to try to eliminate it.
Absolutely. And I would totally agree with you. I really enjoy the multidisciplinary work. I've learned so much from working with other colleagues, particularly dermatology colleagues. And the other thing I think that drew me to vulval medicine is that, eventually I think I'm probably going to get too old for obstetric on calls. And I think vulval medicine is something that has longevity within your career.
Yes.
So how is a vulval consult different from your standard gynaecological consult?
And one of the big things is that a lot of the women will come to us without much in the way of symptoms or no symptoms at all. And if they do have symptoms, they have itch and pain. And that's common across most of the conditions. So you actually don't get very far in making a diagnosis just by your initial questions. You end up digging a bit deeper into things like what's going on the skin. So what wipes or creams or pads or chemist products are being placed on the skin. A lot of women have had multiple previous treatments, so you need a lot of specifics about what dose, how long for, how did it work, where were you putting it. You end up digging into things like changes in the vaginal discharge and sexual impacts that women might not bring up straight away. And you always ask about any skin issues anywhere else because genital skin conditions aren't just limited to that particular area. I find a lot of people have musculoskeletal problems And that creates a superimposed pain syndrome. So I'm asking about accidents and injuries and traumatic events to the vulva and vagina. And finally, there's a lot of medications that are really pertinent to the history. So estrogen, antibiotics that were taken recently, steroids, immunosuppressives, biologics, and SGLT2 inhibitors.
SGLT2 inhibitors are one of the newer diabetic medicines.
Precisely, and they're so popular for diabetes, and they've got great evidence behind them for that. But the problem is that they're associated with candidiasis. And these women already have a predisposition to candidiasis often because of their body habitus and their diabetes. And so it's quite a common story that someone will have well-controlled lichen sclerosus and then come into you much worse, saying their steroids don't work, lots of pain, lots of itch. And then you find out they've been recently placed on an SGLT2 inhibitor, and when you take a look, there's a red rash all over the vulva.
Yeah, and you've started to move on there to examination findings. So perhaps we could talk in a bit more detail around that. Yeah. I guess to start with, maybe your approach to your sort of general vulval examination.
I try to start the examination in the consultation room by explaining to the woman what to expect, because it is different. So I talk about the chair and the screens that we have, and that I use a colposcope, and that's for lighting and magnification. And I talk about the skin inspection and how I don't always have to do a speculum examination. That really depends on what's going on. And I also review the sort of investigations I might be considering doing. So swabs and biopsies, skin scrapings. And then the approach itself needs to be systematic like everything else we do. I tend to start at the top and work my way down to the intergluteal fold. And I'm trying to assess all parts of the vulva, so hair-bearing skin, hairless skin, and non-epithelialized squamous epithelium, non-keratinized squamous epithelium. And I'm also trying to look at skin folds, and there's a lot in our area. We've got intrapannis and inguinal and genitocrural and the interlabial and intergluteal. So after doing all of that, I move on to the extragenital skin examination, and I've usually used my findings to inform that, but you can do it the other way around. And so if I'm thinking about psoriasis, I try to look at the scalp, the eyes, and the ears, so behind the ears, but also in the ear canal, and the nails, and the extensor surfaces of arms and legs, particularly if they're already exposed. And if I'm thinking about lichen planus, then I'm looking at the mouth and the scalp and the extensor surfaces. And candidiasis also tends to happen in the mouth, but also in the other skin folds, so the axillae and inframammary folds.
That's really interesting. I've always done my extragenital examination first as a sort of soft landing into the more intimate. But the idea of doing it the other way around and then having a slightly more targeted approach, because you kind of know what you're thinking you're looking for, is maybe something I'll think about changing my practice. And then, so thinking specifically about examination findings in lichen sclerosus, what sort of things would you be expecting to see?
So one important point is that you don't need acetic acid to assess a skin condition. And in particular with lichen sclerosus, where there's so often broken skin, it's extremely painful to put acetic acid on, and it doesn't help you make the diagnosis. And worse still, it can actually confuse the picture, because acetic acid tends to be taken up in the mucocutaneous junction and also in any skin that's irritated. So if you're not familiar with that, you end up biopsying something that's normal skin. But as far as what lichen sclerosus tends to show, it is usually white to pink-white color change, but that can be focal or generalized. It's often not in that classic figure of 8 distribution that you read about in the textbooks. And you also see texture change. So that might be a thinned, crinkly texture, or it might be a thickened texture, usually with a rough surface, and that's often due to rubbing or scratching. And then you have architectural change. So anteriorly, that might be seen as a flattening of the clitoral hood, or adhesions between the glans clitoris and the clitoral hood, or you might see a blunting of that division of the upper labia minora into clitoral frenulum and clitoral hood. And the labia minora may be smaller in size than they were previously. They can adhere to the interlabial fold, and they can resorb partially or entirely. And then you can get a fibrotic change to the clitoral frenulum, and also to the posterior fourchette that sort of functionally limits the introital size and can lead to sexual problems. So some people will have all of these findings, and it is possible to end up with really no specific vulval anatomy, labia majora, that just kind of converge into the vagina. Or some people may just have a focal anatomic change.
And I think this might be a good opportunity for me to spruik your book, written with Melissa Mausker and Amanda Selk, came out from the ISSVD last year, which just looks at the kind of practical examination, management, everything through lichen sclerosus. But there were some excellent photos in the examination section, because you really do need to see it on multiple occasions, to see those different patterns and learn that pattern recognition to make the diagnosis confidently, on the sort of clinical examination side.
Yes, thank you. And I think we also have some examples of fissures and petechiae and ecchymoses, the types of traumatic findings that can result from inflammation, but also from just everyday activities that cause minor trauma.
And from scratching, yeah, absolutely. We'll be back with more after this quick break.
The RANZCOG annual scientific meeting is back for 2025, and this year we're bringing it to Adelaide. Heather, what do you have in store for us?
Thanks, Nisha. We're really looking forward to hosting the RANZCOG ASM, and from the 18th to the 22nd of October, we would like everyone to join us at the Adelaide Convention and Exhibition Centre for 5 inspiring days of learning, insight and also real connection. This year's theme, From Conception to Curtain Call, reflects the full journey of women's health, with sessions covering fertility and pregnancy to menopause and beyond. You'll hear from the global leaders in the field, including Dr Matthew Leonardi, Dr Laura McGee and Dr Linda Brubaker. Plus, we've got some excellent hands-on workshops planned, and don't miss the gala dinner. It's going to be a chance to network, dress up and unwind with colleagues. You can earn 23 CPD hours for attending the full program.
That sounds fabulous. I can't wait to join you in Adelaide.
For anyone who is wanting to join us, visit ranzcogasm.com.au and come visit us in Adelaide.
Looking forward to seeing you all there.
Welcome back. So moving on through the assessment and thinking about investigations you might do, you quite often take a skin swab when you're doing a vulval examination?
Yeah, that's right. I'm usually taking a swab for culture if I'm thinking about candidiasis. But if I'm investigating vaginal abnormal discharge, then I will be taking a wet mount. And so that's 2 swabs. And you don't need a speculum to take these swabs. You can just use a plain cotton tip for the wet mount and then your standard package swab for the vulvovaginal culture. And for the wet mount, I'm trying to get the discharge on the vaginal sidewall. For the culture, it really doesn't matter. You can use your swab in the vagina and also on the vulva or in one of the skin folds. And you just send that as one culture because it's a global problem.
I've seen wet mount done like in sexual health clinics and as part of my training. It's not something I do routinely in my practice. I think it's done more extensively in North America. So
Yes.
yeah, it's interesting to hear that you do that routinely.
Yeah, for a specific indication.
Yeah.
But it is considered sort of standard of care in North America and many parts of Europe to do a wet mount to assess abnormal discharge complaints. And it is a really fun and easy thing to do, but it takes the equipment and it takes a learning curve. So you usually have to attend a course or conference for a day or two and then practice. What it's really good for is desquamative inflammatory vaginitis. So if you're seeing lots of white blood cells and parabasal cells, which are smaller epithelial cells that indicate a high turnover of the epithelium, and then a background flora with a coxobacillary shift, that makes you think about DIV. But whenever you're thinking about it, you also need to check for trichomonas. And while you can see the trichomonads under the microscope, and that's very exciting, especially for the trainees, it's not a very good test for that, so you should do a PCR as well. So I tend to do a PCR for trick if I'm worried about DIV or if I'm thinking about PID.
Oh, interesting. Yeah, maybe something I should think about for the future. One of the other key investigations in vulval medicine is the biopsy, and obviously there are a few different ways of taking the biopsies. And can you just kind of talk us through your approach to vulval biopsies?
Absolutely. So biopsy is so fundamental, not just to getting the diagnosis right, but also to improving as clinicians, because you can think about your presumptive diagnosis and then compare it to your biopsy results and then put that together with how the woman responds to therapy to sort of internally audit how you're going. Biopsy is an exercise in clinical judgment in that you need to choose the right timing and the right site to maximize the yield, and you need to inform your pathologist about what you're thinking. So my advice is generally that if people have absolutely no idea what is going on, then they may not be best placed to take the biopsy, and it may be better to refer on to someone who can generate a differential diagnosis and make those clinical judgments about site and timing. As far as site, it needs to be according to what you're assuming is going on. So for neoplasia, you need to biopsy the worst appearing area, and that might be in the center of a larger lesion in an ulcerated and hard area. And you need to go down the whole thickness of the punch biopsy. But for a dermatosis like lichen sclerosus, you want to biopsy the most typical appearing area. And you don't have to use the whole thickness of the punch. You really just need epidermis and dermis, not the deep stroma or the fat. And if you're seeing multiple different morphologies on the vulva, you may need to take more than one biopsy. And then it often comes up about ulcers or immunobullous disease. Where do you biopsy? And you need to go to the intact epidermis just to the side of the lesion. Because if you send a pathologist skin biopsy that doesn't have any skin, then they can't really give you any answers.
And I think your answer also draws back to that multidisciplinary team approach that's really important in vulval medicine. Like the quality of the information you give to your pathologist on the request form is really important, like what you've seen and what you're thinking about. And then usually having that opportunity to have an MDT discussion at some time and go through the their findings compared to your clinical findings and put that together is a key part of vulval medicine.
Yeah. And on that form, it's really important to localize where you took the biopsy with laterality and an anatomic position and not use a clock face, because that's not really informative on the vulva. And then you want to just provide a couple of words about what you're seeing. So white plaque, red patch, and then your leading diagnosis or a very brief differential. So lichen planus versus H-sil. And that will ensure that any pertinent stains are done, that the pathologist already has in their mind, whether they need to do extra levels.
And on a more practical basis, would you normally close your biopsy site with a suture, or do you put on a hemostatic agent? And then what sort of advice do you give about post-biopsy care? And I guess thinking about lichen sclerosus, when would you advise patients to start or restart their steroids?
Yeah. I tend to use ferric subsulfate, so Moncell's solution, because that's what we have available. Silver nitrate is also really functional. If I know someone has a tendency to bleed or they're on one of those medications, then I'll think about closing with a suture. But generally, a little bit of pressure and Moncell's is enough. And I tend to tell people that they can use the steroids straight away on the rest of the vulva. They're just not going to rub it directly into the biopsy site. And my advice is that it doesn't need any special lotions or potions. They just shower normally and pat dry. And if they're seeing expanding redness and having worsening pain rather than getting better, then they should go see their GP or call into rooms if it was a private setting.
Mm-hmm. So thinking about sort of a classic first diagnosis of lichen sclerosus, what's your initial management plan for your patients? What advice do you give them?
I try to be really explicit about the treatment goals. And that's because this is a chronic, lifelong condition, and people need to know what we're trying to achieve. So the first goal is to control symptoms and improve quality of life. But if patients are asymptomatic, that's not really an issue. It's about those three other goals. And the second one then is objective control of the disease. We're aiming to have a near normal or normal color and a normal texture. Third, we want to prevent or arrest the architectural change that is associated with lichen sclerosus. And then fourth, we want to prevent cancer. So once we go over that, I talk about how topical steroid ointments are the mainstay of treatment, and we know that proper use of steroids achieves those goals. And you can individualize the regimen to the severity of the disease and also to that particular woman's life needs. So to start, to get the disease under control, you're often using a high or super potent steroid ointment, so something like betamethasone dipropionate or clobetasol propionate. And you're doing that usually every day or even twice daily for months. But once you've achieved that normalized color and texture, then the woman can transition to some sort of maintenance regimen, which again is individualized based on how things are going. So that might be a high potency steroid twice a week, or a moderate potency steroid twice a week, or a moderate potency steroid every day. And some women with really quite mild disease can be controlled with hydrocortisone ointment daily. So the huge take-home point here is that there is no correct drug and no right regimen for lichen sclerosus. You can use a whole variety of steroids and a whole variety of frequencies so long as you're achieving those 4 treatment goals.
Yeah, I tend to wean by time, but there are definitely patients who I think find it easier to remember to put something on every day. And so then weaning by potency just works much better for that patient cohort.
And there is dermatology evidence to suggest that daily administration is associated with much better adherence than a couple times a week.
And so we talked a bit about the medical management. What's the role for surgery in lichen sclerosus?
There's not that much role for surgery in lichen sclerosus. The times where it comes up is when someone has a functional limitation or functional disturbance that is directly attributable to the architecture change of lichen sclerosus. So one example is if you have a clitoral phimosis and that's producing clitorocele recurrent infections, or it's producing sexual pain, then you can think about doing an opening of that adhesion. And the other common situation is that fibrotic change of the clitoral frenulum or the posterior fourchette. And if you divide that, it can alleviate some of the sexual difficulties. But the steroid management of the lichen sclerosus needs to be excellent before and after the surgery. Otherwise, you just have a readhesion and you're right back where you started, but now you have even more pain because you've operated in the area.
Yeah, there's always going to be a risk of dyspareunia, and obviously lichen sclerosus is Koebnerizing, so it does tend to go to where there are scars.
Precisely.
So good control is paramount.
Yeah.
And so speaking about that, what about patients who either don't seem to respond to steroids or have responded to steroids and then it seems to be working less well? How do you approach that sort of treatment? Not failure exactly, but if difficulties with steroid.
Yeah, I think that's one of the more challenging areas and something that you really get better with over time and with volume. And it's difficult because you need to start at the beginning. If someone isn't responding to steroids with lichen sclerosus, they should respond. So you first ask yourself, what is going on? Do I have the correct diagnosis? Or is there another diagnosis that I haven't yet picked up? Lots of the dermatologic conditions are comorbid with lichen sclerosus, so things like erosive lichen planus and psoriasis, candidiasis, superimposed pain syndromes, estrogen deficiency, and many more. So you're thinking about what else is going on. And you're also thinking about, is my treatment going where it should be going and often enough? And there is a lot of steroid phobia in the community. And so it takes, again, quite probing questions to figure out if the problem is actually just not enough steroid. And there is an algorithm that we put together in the lichen sclerosus book. I think it's on page 111.
Oh, wow. Quoting page numbers.
That's right. That goes over your clinical approach based on what you're seeing. Because say, for example, you're seeing a lesion within a larger field of lichen sclerosus that isn't responding to the steroid, well, that's a whole different pathway. And there you're concerned about neoplasia. So you're needing to take a biopsy. And then if you don't get the answer that you were expecting, go through that process, as you were discussing, of some clinical pathologic correlation discussion with the pathologist MDT.
I guess issues that I've seen with patients that haven't responded, sometimes when they have responded and then relapsed, that's because they've picked up candidiasis. So that can be quite common.
Such a common.
And, just not realised it. And the other thing is sometimes with older women who don't have great mobility or hand dexterity, and perhaps are also a little overweight, that they're putting the steroids more on the hair-bearing areas, on these sort of outside parts of the labia, and not really getting into where it needs to be. And you can actually tell that again because you get that steroid atrophy, that steroid redness, where there shouldn't really be any. And the vulval examination, ideally with a screen, so you can talk the patient through exactly where they need to put their steroid ointments, can be really really helpful, I think, for that.
Yes. And the package labeling on steroid ointments very problematically says to not put on internal surfaces. And a lot of women read that as the hairless skin of the vulva, even though we know that that's not internal. Women have no reason to know that.
Yes. Yeah.
Unless you tell
the
them.
dividing line between internal and external might be obvious to them, to us, but it's not obvious to patients. And so thinking about the sort of long-term lichen sclerosis management, we've talked about steroids, but what are the other aspects of care to improve vulval health?
You end up needing to go over multiple times vulval care practices. And I think that's in part because we have so many cultural practices that are not in keeping with good vulval care. And these are constantly getting reinforced through social media and the community. So you have to undo a lot of that. So I spend time talking about the use of a barrier ointment or oil, so an emollient, at least once a day, every day. And that's usually at the opposite time of the day to when they're treating with the steroid. And I'll reinforce issues around hygiene. So we tend to overwash in this society and use a lot of soap and other products with multiple additives that serve as irritants or allergens, especially wipes. Wipes are a real enemy of the vulva. And I'll talk about alternatives to pad use for women who have menstrual, still have menses, or women who have incontinence. And I'll also tailor some of the advice to other life stage issues. So if women are sexually involved, then talking about lubrication and sexual practices. And at every visit for follow-up for skin problems, you need to examine the skin and see if you're meeting those treatment goals, if there is objective control of disease, and titrate the steroid accordingly. And I also think it's a key role to recognize with women that it is hard to manage a lifelong chronic condition. It's hard work. It's a journey of acceptance. And so I try to acknowledge that and congratulate women on their success for doing something that is really not easy, especially younger women. And finally, we can address some of the other things that come up around advice that's been given about a particular product or challenges they're finding with using the steroid at a particular time or in some settings. So there's a lot of work to do in the follow-up visits.
Absolutely. And I do think when I'm seeing women sort of sometimes for an annual follow-up who are a bit more stable, that with any chronic disease, people forget to take what they should be doing. So I suspect the steroids get used a lot in the 2 weeks before my clinic and the 2 months afterwards, more than they do in the other 9 months of the year. But it is important to kind of emphasize that they are going to need maintenance, because even when they're asymptomatic, you can see skin changes and you can see architectural changes that happen before people become symptomatic again. And over time, those just add up and lead to loss of function.
And when you're using a screen or a mirror or photographs, it's really helpful for the women to see that even though they feel great, things are not as good as they could be.
Yeah, absolutely. Yeah. And so when do you think that the general gynaecologist should refer on for a more in-depth approach? When would you ask for a second opinion, say? Or when would you expect a general gynaecologist to ask for a second opinion in vulval care?
Yeah, I also ask for second opinions. And the first one is a common one for me, is if you're dealing with a child or an adolescent with a skin problem and you don't have a lot of experience with pediatric dermatology, or you haven't done a pediatric and adolescent fellowship, then it's probably best to refer on. And that's so true for melanocytic lesions. So they're really difficult to assess clinically. And then the histopathology is one of the more difficult tasks as well. So you can really go down a unsatisfactory path if you try to deal with that yourself. If you cannot find the diagnosis, if it's something that seems quite unusual, doesn't match any of your pattern recognition, it's probably best to send it on to someone who has that broader dermatologic experience. And likewise, if someone has a lot of extragenital disease in addition to the genital disease, that's not really appropriate for a gynecologist to take care of. We tend to focus our treatment on topicals. And many of those patients are better served by a systemic approach with biologics.
Yeah, I found that working with the dermatology colleagues, there seem to be new medications coming out all the time with very fancy long names that I mostly can't pronounce, with sort of strict criteria as to which ones different patients can have, and often need a lot more sort of investigation and follow-up that we'd be comfortable doing in a vulval clinic, I think.
And then that final issue we've alluded to before is when you have a discrepancy between your clinical impression and your pathology results. So in that case, there's different ways to refer, so to speak. You can try to get a different pathologist involved. You can have an MDT, or you can send to a center that does more of that kind of work. But you can't just take the report on face value as being correct, because this is a really difficult area for pathologists as well.
Yes, and I guess you're meaning like if you think there could be some chance of a pre-malignant
That's right.
condition.
A precursor lesion, particularly the HPV-independent precursor lesions, are quite difficult to diagnose.
Yeah.
But you can see that there's something not getting better with the steroids. And that's the trigger to think that if I'm not getting the answers I need to keep pursuing this.
Well, thanks so much for taking the time to talk to us today, Tania. I've learnt a lot. What do you think are your key takeaway messages?
The first is that an individualized steroid regimen for lichen sclerosus is safe, effective, and life-changing. So we all have the capacity to work with our patients to do that. The next is that this field is about making a diagnosis. We've touched on that a couple of times, but it sometimes requires all these extra steps of extragenital examination, swab, PCR, biopsy, clinical pathologic correlation, and assessing how people go over time, maybe repeating an aspect of an examination. But it is essential to get the treatment right, that we know what the diagnosis is. And then finally, in concert with vaccination, vulval cancer is a totally preventable disease. And if we can identify and manage the lichen sclerosus early, and we can detect precursors, be they HPV-associated or HPV-independent, and treat them, then we can eliminate the disease. And that's, again, within the scope of every gynecologist.
Such a powerful message. Those are great points. If I may, I would add to it, just to echo what you said earlier about acetic acid being really not very necessary for the vast majority of vulval examinations and causing unnecessary discomfort to patients. Thank you so much. This has been a great conversation.
Thank you.
If you enjoyed this episode, don't forget to rate, review, and subscribe wherever you get your podcasts. You can also log this episode for CPD hours. The form is available in the show notes, along with links to Dr. Day's book, the ISSVD Practical Guide to Lichen Sclerosus, and the O&G magazine edition themed around the vulva. Thanks for listening, and we'll be back soon with more from Talking O&G.